Hi, good afternoon. My name is Aman Ali. Today I'll be presenting on postoperative complications in sleeve gastrectomy and how they're independent of staple height and staple line oversewing. The senior author was Dr. Patrick Reardon, who's also here in attendance today. I have no disclosures. Since 1980, the prevalence of obesity has doubled in more than 70 countries worldwide. Between 2007 to 2018, the age-adjusted prevalence of class 3 obesity has risen from 5.7 to 9.2%. Sleeve gastrectomy is the most commonly performed bariatric surgery nationwide, with over 100,000 surgeries performed annually in the United States. At different hospitals, there's different techniques and variations in how to perform a sleeve gastrectomy. The most common approach is laparoscopic. Dissection starts 5 centimeters proximal to the pylorus. Division of the omental attachments and short gastric vessels with energy device is then performed. An endoscope or bougie is inserted along the lesser curvature and guides the transection of the stomach. Then the transected portion of the stomach is then removed. The staple line is often assessed for any residual bleeding, and if needed, hemostasis is achieved. Oftentimes, an intraoperative endoscopy is performed to assess the stomach and the staple line. Common postoperative complications include staple line leak and bleeding. Surgeons have attempted various techniques and tools to avoid these complications, including staple line reinforcement, oversewing the staple line with running absorbable suture, clipping of the staple line, different branded staplers, and staple heights. As you can see, there's significant variability in the specific tools and methods employed in sleeve gastrectomy. Our goal of this study was to analyze factors such as the type of energy device used, the type of stapler, the height of the staples used, and use, if any, of any staple line reinforcement. We also went to assess the relationship these factors have on postoperative complications such as staple line leak and postoperative bleeding. We performed a retrospective cohort analysis of patients who underwent sleeve gastrectomy at Houston Methodist Hospital between 2005 to 2019. 23 different surgeons actually performed the procedures. 87% of the cases were performed by 5 surgeons. Our total population included 1,213 patients. Our exclusion criteria included liver transplantation, cirrhosis, end-stage renal disease, being on anticoagulation for left ventricular assist device. 52 of these patients met the exclusion criteria. In the end, we had a total of 1,161 patients. We collected data on patient demographics, comorbidities, and procedure details. Specifically, we looked at the bougie size, the type of energy device used, the staple height, the number of staples used, the staple distance from the antrum, staple line oversewing, staple line clipping, and DVT prophylaxis. On the right, you can see the different heights of the different staple loads that were used. Differences between groups were evaluated using the chi-squared and the Kursal-Wallace test. Multiple logistic regression analyses were performed to determine which factors contributed to postoperative complications, including bleeding, which we defined as requiring blood transfusion and surgical hemostasis, staple line leaks, which were confirmed radiographically, and composite events, which was defined as patient having bleeding, transfusion of packed red blood cells, or a staple line leak. A p-value under 0.05 was considered significant. Our results included 21% males and 79% females with an average age of 43 years. Our average BMI was 43.4. In terms of patient demographics, increased age correlated with increased bleeding occurrence and requiring blood transfusion with a p-value of 0.03 and 0.01. There was no correlation between gender and BMI in terms of bleeding occurrence or requirements of transfusion of blood and leaks. We looked at the staple types. We looked at Ethicon, Covidian, the robotic short-form stapler, and we found no correlation between bleeding occurrence, the requirements for blood transfusion, or leaks. We looked at different energy devices, including ligature, NCO, harmonic, vessel sealers, and that's a robotic vessel sealer, and we found no difference in terms of bleeding, blood transfusion requirements, and leaks. We also studied staple height and staple line management techniques. Different staple heights did not show any correlation in the rate of bleeding, blood transfusion, leaks, or composite event. Different staple line management did not show any correlation to the rate of bleeding, blood transfusion requirement, leak, or composite event. In terms of anticoagulation, patients that were on anticoagulation preoperatively did not have any increased risk of bleeding or requiring blood transfusion. Same with preoperative prophylaxis. Patients that received post-op prophylaxis showed an increased rate of bleeding and blood transfusion 0.002 and 0.04 for the p-values. For the patients that bled and required blood transfusion, they stayed in the hospital longer, which was significant with a p-value of less than 0.001 with an average length of stay of 3 days. Some of the limitations of the study, this is a retrospective study, and this is also a single institution study. Keep in mind that this study involved 15 years with over 23 different surgeons, and we had over 1,000 cases to report. In conclusion, there's no difference in bleeding, blood transfusion rate, and leaks between using different energy devices, using different staple brands, staple height, use of reinforced staples, or staple line reinforcement techniques with oversewing and clipping. Staple line leak rates have been reported to be between 0.7 and 7% in recent literature. Bleeding complication rates have been reported to be between 1 and 5%. And our study showed a bleeding rate of 0.8%, blood transfusion rate of 2.2%, leak rate of 0.2%, which is lower than the MBSA QIP leak rate of 0.22%, and our composite staple line complication rate of 2.4%. Comorbidities such as end-stage renal disease on dialysis, cirrhosis, anticoagulation use with LVAD patients were strongly associated with postoperative bleeding and transfusion requirements. I want to thank SAGES for allowing me the opportunity to present today. I'll be open to questions.